Hello, I'm John Keane. I'm a GP in west of Leeds, and I've been asked to look at the DVT pathway by Leeds practices in the west to try and improve it. I'd like to introduce the new pathway to you. The pathway has got two aims. One, to make the pathway compliant with NICE guidelines to get anticoagulation given to every patient within 4 hours. And secondly, to improve and reduce the costly patient visits to hospital by triaging better through primary care. This forms part of the quality improvement work with the Leeds West CCG, and on average there are 1 to 2 patients per Leeds West practice per calendar month. The current system is wasteful and is not NICE compliant, and if you are like a GP like myself, the system is quite wasteful. So what we would first do is see a patient with a suspected DVT, and then we would then phone up primary care access line and refer them to the hospital. The hospital then would take bloods, would assess the patient with a nurse probably first and then a doctor, and then they would wait for the blood results to come back, and then finally order an ultrasound if needed, and then at the very end give the anticoagulation. That is a wasteful system. So the case for change, if I can sell it to you. Firstly, there is wasted resources. The anticoagulation of patients who have been suspected with DVT will increase from 38% to 100% of patients in Leeds West. Secondly, there will be reduced duplication of patients going down multiply to A&E. There will also be a number of patients who won't ever need to go down to A&E. There's currently likely to be 14 patients per calendar month in the Leeds West area who will not need to go down to A&E at all. There is a lack of NICE compliance with the guideline of the 100% of patients which should be having anticoagulation within 4 hours of a DVT being suspected. Currently the average times for the city are 4.8 hours, and the percentage of patients achieving that target is only 38%. So I hope I've built a case for change. So I'd like to propose that we have 4 benefits from this new change. 1, we become 100% NICE compliance, increasing from the current standard of 38% of patients to 100%. Secondly, that we reduce duplication of patients being seen multiple times. Thirdly, that we reduce the number of patients who are sent down to hospital at all. And fourthly, if we can prove a case for change with the CCG in terms of reducing cost and showing patient flow as improved, then we can build the change for further ambulatory care models with the CCG. This resource then will come back to general practice and improve further patient care. I would like to demonstrate the new template which assists the DVT pathway, both on System 1 and EMIS. We will be doing photoshops of the template, so you'll be able to see these. You can load those onto your system on System 1 by searching on the lower left part when you've got a patient record open, looking at Leeds DVT pathway version 2. So let me share the 5 changes to this pathway. Firstly, GPs are to assess the patient with a DVT score, the Wells score. It is on the pathway, which just is a simple clicking the box and it brings up the calculator. Secondly, the GP would then check if this patient is suitable for ambulatory care. On the second page of the template, there are 4 areas which are not suitable for ambulatory care. Those with access or consent issues. Secondly, those with clinical concern or complicated or an unusual DVT. Thirdly, those who are contraindicated for the low molecular weight heparin, and fourthly, those with bleeding disorders or coagulopathies. So assuming that the patient is suitable for ambulatory care, the GP would then arrange bloods at that point, and also weigh the patient as a priority. There is a button which clicks onto the ICE panel, which would then load up the appropriate blood tests which are needed for the tests, which include a D-dimer. Next, the GP would then give or delegate the giving of the tinzaparin subcut injection to the patient. There is also a picture on how to do this and the instructions on how to do that. The important thing is that the dose is weight dependent, and therefore the patient must be weighed, and then the excess, which is not needed to be given, is discarded. A patient information leaflet then also can be printed out direct from the template. Finally, the template needs to be sent by an e-letter to the ambulatory clinic. There is an email address on the template, and there is a button which clicks and opens the e-letter, which is pre-populated and literally needs to be checked. The key thing with the checking of that template is that the mobile number is accurate, because once the blood tests are back, the A&E nurse will call the patient directly, and this means that the contact number for the patient is absolutely crucial. So just to summarise, the tools which will help to complete this pathway are on System 1 and EMIS, and they should be able to be straightforwardly used. There is agreement also from pathology that we can send samples down out of hours using a taxi service. Please write on the blood form urgent so that it can be processed at that point. The taxi journey will also be able to be reclaimed from the CCG. The supply of the tinzaparin will also be reimbursed, but only one strength will be stocked, and the extra, as I've explained, must be discarded. So just to summarise the 5 steps which we've got. First, you would click the box to say it is suitable for ambulatory care. Secondly, you would collect and calculate the well score by examining the patient and weighing the patient. Next, you would take the bloods using the ICE panel. Fourthly, you would give the tinzaparin and the patient leaflet. And fifthly, you would email the clinic the form, the e-form, which has been pre-populated. It may be then that you would then ask your healthcare or nurse to reorder the tinzaparin. Thank you for your help, and please do email me with potential or actual problems with this pathway. My email is johnkeen@nhs.net.